Dr. Vinay.
Yeah, hello, madam.
Yeah, good evening, sir. Are you able to hear us, all of us?
Yes,
Yeah,
ma'am.
you able to hear me?
Yeah, I can hear you. Are you able to hear me, ma'am?
Yes, sir. Yes, I can hear you. You are visible also. You're...
Okay. Thank you, ma'am.
Yes. Thank you, sir. So we'll start in about 5 minutes.
All right.
People are joining in. Yeah.
Yeah, sure.
Dr. Vinay, can you hear me?
Yes, ma'am. I can hear you. Just a minute. Okay.
Yeah.
Just wait for.
I will start.
No. Just wait for 2 minutes, ma'am.
Sir, I will start with the introduction, following which.
Yeah. Sure.
Yeah. So, good evening, everyone, and a warm welcome back to this IAMM KC Masterclass series that we have been having from the last couple of months. And today we are going to have a much awaited session titled Neuroinvaders, where the spotlight will be on parasites targeting the central nervous system. And to deliver this session, we have a very prominent person, Dr. Vinay Khanna, who is working as Associate Professor in the Department of Microbiology at Kasturba Medical College, Manipal. Dr. Vinay, a warm welcome to this session, and it is my pleasure to introduce you as a speaker for this masterclass. Dr. Vinay has a special interest in parasitology. He also has a FAMER fellowship and holds an MBA in healthcare management. Dr. Vinay has more than 15 years of teaching and diagnostic experience, and he is a lead trainer for the Medicine Sans Frontiers Southeast Asia, and also is one of the main trainers for the Diploma in Tropical Medicine and Hygiene. Dr. Vinay is a well-known expert in diagnostic parasitology and closely collaborates with the London School of Tropical Medicine. Sir is an EC member of Indian Academy of Tropical Parasitology and also the secretary of the Karnataka State Chapter. He has, through these organizations, trained a large number of postgraduate students, faculty, both from India and abroad, in diagnostic parasitology. He has several research papers and grants to his credit, to just mention a few, from Navitas Life Sciences, from ICMR, etc. He is a member of American Association of Microbiology, the European Society of Clinical Microbiology and Infectious Diseases, and Indian Academy of Tropical Parasitology. Sir, on behalf of IMMKC State Chapter, the EC members, and the Masterclass team, a warm welcome to you as the speaker of this session. Over to you.
Thank you so much. I just want everyone to wait for just 1 minute because I am doing some changes in my PPT. Just 1 minute. Give me 1 minute. Thank you.
Sure, sir. This is for information of all the participants. As the session is progressing, if you have any questions, queries that need to be asked, please leave them in the chat box and we'll definitely take them up at the end of the session.
Madam, I'm not able to find out this presenter view.
Sir, but you have already shared your screen. We are able to see it.
Are you able to see my screen?
Yes. It's on the first slide. Can you put it on slideshow?
Yeah, 1 minute.
Yes. Perfect. Now it's come.
It is coming?
Yeah, it came and now it's reverted back to.
1
Just
minute.
put it on slideshow, sir. It's fine.
Yeah, 1 minute. Let me check.
Yes, sir.
Are you able to see mine now?
Yes, it's going back to the normal mode from the slideshow, but just now it came on slideshow.
It came? Why it is
Yes.
going? I think it's not moving. Let me check. In between it came and then it stopped. 1 minute. Just a minute, madam.
Yes, yes, sure, sir.
Ma'am, is it there now?
Yeah, it is on slideshow, sir, now.
Okay. Are you able to hear me clearly?
Yes, yes.
All right, ma'am. You can see my screen, right?
Yes, yes, sir.
All right. So we'll start for the PGs. So many PGs are there. Staff members are also there. So I take this opportunity to thank IAMM Karnataka chapter to share my thoughts and my experience in CNS parasites, right? So what are CNS parasites actually? Actually, ma'am, there is again and again some waiting is coming, admit and all. I don't know. Anyways, so there are two types of basically parasites which are called as natural parasites, and another one is opportunistic CNS parasites, right? So the natural parasite can infiltrate the healthy individuals. Okay, it can attack the blood-brain barriers, endothelial cells to access the CNS tissue. So example for this is free-living amoebae. And then we have certain opportunistic CNS parasites that do not infect, or rarely they may affect the immunocompetent individuals. But immunocompromised are at risk. So what they do is that they'll affect the endothelial cells of blood-brain barrier, causes the increase in the permeability and allows the parasite to enter into the CNS. The classical example is Toxoplasma gondii. So here you can see the picture of various protozoal parasites which can affect the CNS. Can anybody tell me which is the first uh, picture? That is, anyone? I want to hear, like, at least should be interactive session. The first picture is written already. Entamoeba histolytica. The second one is Acanthamoeba. You can see the classical Acanthopodias. And the third one is Naegleria. And then we have Sepinia, Balamuthia, and Vermamoeba. So Entamoeba histolytica was first discovered in Russia from a farmer who was suffering from dysentery. And anybody knows who was the discoverer? Okay, I think everybody's quiet. So it was Losch. And usually the cerebral amoebiasis occurs secondary to the systemic involvement. Okay, and it occurs in less than 10% of the cases, but it is quite rare. But what about the other free-living amoebas? So they can pose a significant risk to the CNS infections. And now due to climate change, they are considered as emerging CNS parasites. So when the Acanthamoeba was discovered, actually it was discovered as contaminant of the yeast culture, Cryptococcus pararoseus. And it affects the skin as well as lungs. We'll discuss that in detail. And the classical is there, Acanthopodias, as you can see here. And then we have Naegleria. A lot of cases has been reported recently from Kerala. It was named earlier as amoeba brewberry. So in 1970, Carter and Fowler basically discovered it, and then it was named as Naegleria fowleri. And the third one is, Balamuthia mandrillaris. Only one species is known to the man, and it was basically isolated from the gorilla. Then we have Sapinia diploideae, which is also a free-living amoeba, and it was isolated from the feces of the lizard. And it also causes granulomatous amoebic encephalitis. Then we have worm amoeba vermiformis, which is a recent addition. And it is quite hard to differentiate the symptoms from the bacterial meningitis. What these worm amoeba symptoms are there, it is quite difficult to differentiate the symptoms from the bacterial meningitis. That's why many cases has been missed. So recently, 2 cases has been reported from Kerala. So now we are going to discuss about the free-living amoeba. So approximately 23,561 cases of acanthamoeba keratitis was found globally, with highest incident in India. Okay, around 15.2 cases per million people has been reported, and it is lowest in Tunisia and Belgium. And there are notable outbreaks are seen in North America, which is linked to contact lens users or solutions. So the rising trend has been seen in Europe recently, particularly from year 1994 to 2018. The data I have till 2018 only. And then variable rates are seen in Asia on the contact lens users. So this is a map which is representing and telling about the incident rate of acanthamoeba keratitis. And you can see the highest incident are seen in India, which is around 15.2. So now the question arises. You can see this diagram, and you can see the continuous rise of these amoebas. So the question arises, are these rare pathogens, and why they are on rise? So there are many explanations, including the rising numbers of immunocompromised patients, because HIV patients are rising, the patient with transplant are rising, the cancer patients are also increasing, and along with that, contact lens wearers are also increasing day by day. So that's why you can see a lot of publication reports. Other thing is that these pathogens are reservoir for different other bacterial or viral pathogens, and they are also used as model organisms for motility studies. So that's why it has generated a lot of research interest in these organisms. And now new studies are been publishing, which are correlating the climate change, especially the warm condition, to the rise of these pathogens. So coming to Naegleria, around 381 primary amoebic meningoencephalitis cases have been reported in more than 16 countries, with the largest number seen in US. And that study was done by Radhika et al. And where they have found that the mean patient age was found to be 12 years, and it ranges from 8 months to 66 years. And majority of them were males and children. 87% of the cases occurred during summer season, and with 81% of them had a water exposure, particularly to the lakes and the pond, while 19% had no identifiable source, and they showed no evidence of immunosuppression as well. So this was published under Oxford University in 2021. So recent update in India. So there was Kerala outbreak, and 3 day back only, there was outbreak in Kozhikode district. I think many of the PGs are from Kerala. They might be knowing about this. And if you are interested in parasitology, you can open the Deccan Hurdle or any newspaper. You can see these reports. 3 children have been affected, and 2 deaths has been reported. So so how they are basically getting? these infections? They are getting because they are exposed to the well water, pond water, which highlight the risk for untreated water. These are basically untreated freshwater sources. And these untreated freshwater sources are commonly used for bathing and recreational activities, especially in adolescent and children. That's how they are getting the infection. That's what actually government is telling, and these are the facts, and this has been published. Now, the first case, a report of primary amoebic meningoencephalitis was reported in Southern Australia by Carter and Fowler in 1965. So what happened actually at that time? So they have reported a series of meningitis cases. Okay, and many people have contracted and died from aggressive meningitis. And there were no causative bacteria which were isolated from blood or the CSF sample. So what these scientists have done, they have done the gross and histopathological examination, which reveal a significant, frontal lobe swelling with flattened gyre. You can see here, if I open the tool, my highlighter, if I have. So you can see here, there is a significant frontal lobe swelling with flattened gyre and sulci. And then hemorrhage is also seen along with the necrosis around the olfactory bulb, nerves, and there was purulent discharge are seen in the sulci and ventricles. So this is the purulent discharge, right? So this is the sample from the cortical tissue, and the smear were prepared from the exudate, and it was stained with H&E stain, revealed small eukaryotic organisms in the cortical matter. So this is 200 time magnification. This is 400 time magnification. Okay. And here you can see the presence of amoeboid forms of Naegleria with granular cytoplasm. This one, right? So, these, so they have a central karyosome and they don't have any, chromatin. And these forms are called as replicating forms. These forms are called as replicating forms, right? Okay. So these are basically cyst of Naegleria, and they have a thick double wall, and they are only found in culture and they don't occur in the living tissue. And if you try to, see in the biopsy, they won't be present. They will not be there, right? So what you will see is only these type of forms. These are called as flagellated forms or amoeboid form. Sorry, these are called as amoeboid forms. And these forms can be converted to flagellated forms if you change the ionic concentration. So this is what the flagellated forms look like here in this video. All right. So what is our experience with the primary amoebic meningoencephalitis? So we have reported a case of primary amoebic meningoencephalitis in 5-month-old infant who has presented with 2-day history of fever, decreased breastfeeding, vomiting, and abnormal body movements. CNS examination revealed bulging and tensed anterior fontanelle with positive Kernig sign and presence of nystagmus. WBC counts were found to be around 17,700 cells per cubic millimeter, with 89% of them are polymorphonuclear cells. CSF count revealed total WBC of 990 per cubic millimeter. The normal value is less than 5. And the predominantly they were lymphocytes. They were lymphocytes. So obviously we have cultured for bacteria and fungus, and we try to look for cryptococcus and all, but it was negative for them, and bacterial culture was also sterile. Microscopic examination of wet CSF preparation showed motile trophozoite of free living amoeba suggestive of Naegleria fowleri. So this is what we have seen. It is motile. So this is a methylene wet mount showing Naegleria fowleri with, you can see the granulars inside, and large endosomes are present, and characteristic lobopodias. So they don't have pseudopodias, but they have lobopodias. Okay. So what happened to this patient then? So final diagnosis of primary amoebic meningoencephalitis was made. The patient was started on amphotericin B and ceftazidime. But his condition was deteriorated and he was taken home in a very, moribund condition against the medical advice. And subsequently, the patient died. And we have reported this case, and you can check online, right? All details are there in that, article. So what we have done is that we try to look for the presence of amoeba in the water sources. So we went to the patient house and we try to look for the amoeba in the well water as well as tap water, but we couldn't find anything. So what is the ecology here? Ecology is that they are linked with the warm fresh water, like ground pipelines, tropical lakes, geothermal waters, heated swimming pools, industrial cooling water discharges, and they are also present in the soil. Okay, and you will be surprised that Australia is the only country where Naegleria fowleri is associated with the public water supply. So what is our experience with Acanthamoeba? So we have reported till now around 6 cases of Acanthamoeba, which was basically some of the cases we have done sequencing as well. Okay. The recent one we have done sequencing. So I'm going to tell you the important cases which we found is useful to the PGs as well as staff. So here is a case of unusual presentation of multiple nerve pulses with granulomatous encephalitis. A 25-year-old patient with a past history of migraine for 7 years presented with change in the character of headache associated with double vision for 3 months, and left eye ptosis was seen for like last 10 to 12 days. Neurological examination revealed multiple nerve pulses involving left, third, fourth, sixth, and seventh nerve with pupillary dilatation. While remaining, the patient was conscious and the vitals were stable. So this was a patient, and you can see the left eye, there is a complete ptosis. The left eye is totally closed. And there was pupillary dilatation as well. So the blood examination, the CBC, which showed WBC count of 13,600, and predominantly it was neutrophilic, and the sample was basically TB PCR negative, and bacteria culture was also negative. CSF showed predominantly lymphocytes with the degenerating cells, low proteins, and high glucose level. And mount showed amoebic trophozoite with acanthopodias. Here you can see the acanthopodias, okay, the trophozoite which we have seen. Then we have cultured on non-nutrient agar with killed E. coli overlay, confirmed Acanthamoeba species. And then genus-specific PCR also came positive for this case. And here in the above picture, you can see the star-shaped cyst of Acanthamoeba, right? So what happened in this case? Then we have started the therapy on rifampicin, cotrimazole, and fluconazole. Patient symptoms resolved. That was very satisfying, and generally the general condition of the patient improved. So, but one question is here: how does the patient got the infection? Because there were no history of contaminated water exposure. There were no history of contact lens user in this case, right? And there were no history of skin trauma. Then we look into the published article, like what would be the suspicion can occur in these type of cases. And another interesting thing about this case was that the patient was SLE. Okay, she was suffering from SLE, and she had positive anti-DNA antibodies, and she was also diabetic. So that's why, and along with that, trophozoites, and you should remember that whenever the patient is having diabetes or SLE, and you are not able to find out any other cause, and you are able to see these type of trophozoites, but you have to see continuously to appreciate that it require an experience, but at least you can culture in your lab. Okay, so so you need to have high suspicion of acanthamoeba in these cases, especially SLE cases, which presented with chronic meningoencephalitis and focal neurological deficits, right? So now we have, acanthamoeba meningoencephalitis, which mimics the TB meningitis. So here, basically a 30-year-old manual labor from Chittadurga district presented with the intermittent low fever and diffuse headache for 1 month. So there were loss of appetite and weight loss. Around 3 kg of weight loss occurred in this patient for the last 1 month. So there was enlarged non-tender mobile supraclavicular as well as cervical lymphadenopathy. There was positive Kernick sign and neck stiffness, which was suggestive of meningitis. And there was no history of diabetes or any other comorbidities in this case. So he was suspected to have extrapulmonary tuberculosis, and his CT scan was normal. But anyways, he was started on ATT. CSF analysis show lymphocytic predominant with low glucose level and high protein level, but normal ADA levels. CSF was negative for bacterial meningitis, including Mycobacterium tuberculosis. Okay. And Cryptococcus latest agglutination test also came negative for this case. Even the sputum was also negative for TB. And then when I saw this structure, I could see some, doubtful amoebic structure. So then I told my PGs and technician, just culture it. Maybe it could be FLA. It could be some acanthamoeba or it could be some other free living amoeba. So luckily for us, the culture came positive, and these star-shaped cysts we could able to appreciate under the microscope. So what happened next? Then patient was started on specific therapy with rifampicin, trimethoprim, and fluconazole. So they were complete recovery within 2 weeks after starting the therapy, and the patient was discharged happily from the hospital. So what this case teaches us? So whenever there is a CSF, lymphocytosis and or neutrophilia and all, so or low glucose, high protein level, which are mimicking the TB meningitis. So initially it can lead to misdiagnosis, and the patient may be put on empirically on anti-tubercle therapy. But fortunately for me, I could able to appreciate the structure which were resembling that of acanthamoeba in the CSF, which raised my suspicions in this case. And ultimately, lucky for the patient that the growth happened on non-nutrient agar, which confirmed the diagnosis of this case. Ultimately, lead to the successful treatment. So that's why it highlights the importance of early identification, and to prevent the mortality and serious complications which are associated with these free living amoebas affecting the CNS. So there's another case. This was quite an interesting case in the sense here actually both patient as well as we were also responsible. 37-year-old male admitted with the chief complaint of headache, blurring of vision, and left side since 15 days with projectile vomiting for the 2 days. Patient had history of left side nosebleed, for which he underwent functional endoscopic sinus surgery (FES). Histopathological examination was positive for aspergillus, and he was started on loading dose of voriconazole along with maintenance dosage. But the problem was of side effects. The patient could not, bear the side effect, and he stopped the treatment on his own at home and started on Ayurvedic treatment. The CT scan was found to be normal in this case. So 1 year later, the patient again came with a complaint of left-sided nosebleed, swelling of the left cheek and bleeding from the left upper gum. X-ray reveals the fungus in the maxillary sinuses. So this was so here the right sinus is fine, but left sinus, it is full of pus and other debris and fungus. So what happened after that? Patient came to the hospital with the symptoms suggestive of recurrent sinusitis, epistaxis, and he was again admitted for antifungal treatment. Nasal swab was taken and the fungal culture isolated aspergillus again. So biopsy report was suggestive of invasive aspergillosis. He was advised with left radical maxillectomy and was again started on voriconazole. He continued voriconazole for 3 months and again went to the Ayurvedic therapy. I don't know why. Maybe because of side effects, or maybe he was feeling fine. So on examination, there was protrusion of the left eye, okay, more than the right. Restricted ocular movement on the left side, and patient had a persistent headache, diplopia, but his hemoglobin was 17.6 gram percent. So then clinicians suspected polycythemia, which was considered as a cause for his headache. So initial CSF analysis was negative for cryptococcal antigen and bacterial culture. MRI was done, which was found to be normal, surprisingly. Later on, provisional diagnosis of hypertensive encephalopathy was made in this case. But the problem had patient worsened further with continuous headache, vomiting, diplopia with bilateral lateral rectus palsy. In view of the persistent headache with all the feature of raised intracranial tension, repeat lumbar puncture was done in this case. Then when I saw this picture, I got a doubt because eosinophil were way high. That was 73%. Okay. So then possibility of fungal meningitis, eosinophilic meningitis, and parasitic infection of the brain were considered. So repeat CSF culture confirmed the acanthamoeba. Okay, this is the report which we have reported to the clinicians, right? But in first sample, there were no amoebic forms. But in the second sample, morphological form consisted with acanthamoeba species were successfully cultured. So these were the trophozoites. You can see how nicely their acanthopodias were, moving. So patient was started on antiparasitic therapy after 20 days of admission due to delayed diagnosis, and then he is come in the hospital with 48 hours of starting the therapy. So out of these 3 cases, because these were 3 very interesting cases, and for the last 6 months, we have also got 3 more cases. Okay, and it is actually quite nowadays it is increasing. So what happened out of these 3 cases, 2 we could able to save, but this last patient was lost because of multiple complications, and they were non-compliant from the patient part as well. Okay, and the diagnosis was compounded because of aspergillus, multiple complications, as well as acanthamoeba infections. So this was a third case. So can anybody tell me which case I'm talking about here in this picture? I think you can write in chat. Okay. You can write in chat. Okay, I'm seeing the chat. Anybody can write in chat. I'm seeing. Somebody's writing rabies, knowledge, balamuthia. I think Usha is correct. It's balamuthia. Okay, very good. Yes, it's balamuthia. Good. So the problem with see here, there is one mistake. This is an old slide. Now the number of cases are more than 300. Okay, there is rapid rise of number of balamuthia cases were seen in 2024 and 25. So the case fatality rate of balamuthia mandrillaris is more than 98%. It was first isolated in 1986 from fragment of the brain tissue of the mandrill baboon, Papio sphinx, that died due to neurological disease in San Diego Zoo in California. And it exhibit characteristic movements such as limax, plasmodium, or reticulated or polyaxial forms. So there are different type of forms which are seen in these cases. So the pathophysiological examination of the animal who were dead, they were necrotizing hemorrhagic encephalitis, which was similar to that of granulomatous amoebic encephalitis caused by acanthamoeba was seen in this case. So then in CDC, they did the gene sequencing, which showed that this organism share around 79% to 82% of rRNA similarity with that of Acanthamoeba. So it has a close, relationship with that of Acanthamoeba family. And the symptoms are also quite close. So this is a quite interesting case. It was reported from the Thailand. He was a 23-year-old Thai man who developed fatal meningoencephalitis 6 months after road traffic accident. And he was basically thrown into the swamp water after, accident. And then he presented with a non-healing type of ulcer on the nose. And he died on, after 2 weeks, in spite of giving the antimicrobial therapy. So autopsy was done on in this young man, and he was found to be suffering from chronic necrotizing brain inflammation. The sample was sent to the CDC at that time, and then they found that this is actually a Balamuthia. And then Balamuthia mandrillaris, trophozoite, and cyst were, seen, and they have done anti-Balamuthia antibody testing as well. So this was quite an interesting case, which was reported from Thailand. Everybody has reported at that time that it is a case of Acanthamoeba, but actually it was not. So as of 2025, approximately 300 cases of Balamuthia amoebic encephalitis has been reported worldwide. Okay. Soil exposure is a key risk factor. There is a 98% of mortality. The problem with Balamuthia that it can affect the immunocompetent individuals. Okay. And you can diagnose either through the wet mount and specifically anti-Balamuthia immunofluorescent antibodies. So as I have already told you that they are morphologically similar on light microscopy. So, you require either a sensitive PCR or you require at least the anti-Balamuthia antibodies to, find out whether it is Balamuthia or Acanthamoeba. And the problem with Balamuthia, it is not easy to culture. Okay, it is not easy to culture. It doesn't feed on bacteria as casually as Acanthamoeba does. So the problem that they cannot be cultured very, very easily. So this is basically the first one is a trophozoite of Balamuthia with long extensions, and you can see that there are no acanthopodias or spinous processes here. And the second picture is basically a transmission electron microscopy of Balamuthia mandrillaris cyst revealed the triple layer wall. So it has a triple layer wall, which consists of a thin wavy ectocyst, and it has a fibrous mesocyst and thick round endocyst. And the cytoplasm contain a lot of vacuoles, vesicles, mitochondria, and then you can see here the chromosome is visible within the nucleoplasm. So other emerging amoeba which are causing infection recently, and clinicians are quite getting interested in these. This one is called as worm amoeba vermiforme. Why it is important? Because recently 2 cases has been reported from Kerala, and which was basically mimicking Naegleria fowleri. Okay, so it can also cause primary amoebic meningoencephalitis. It was basically previously under-recognized pathogen, and it is found in different type of water sources, and it can cause keratitis in contact lens wearer and swimmers as well. And it is frequently misdiagnosed as bacterial meningitis because the clinical presentations are quite similar. So you should remember it as worm amoeba vermiformis. I will show you how it looks like. So this is the morphology of worm amoeba vermiformis. The trophozoite is elongated. Okay, they're quite elongated. You can see here. The length is around 10 to 25 microns. Okay, which exceed around 6 times more than that of width. And they have a single nucleus with central nucleus, nucleolus. You can see here. The cysts are smooth. Okay, cysts are smooth and they are not double wall. And sometimes they look oval, and they have a single wall only. Okay, so you should be prepared for seeing these type of cases in India. So coming to the conclusion of the first part of my talk. Okay, there's a second part of my talk is also there. Okay. So CNS amoebic, infections are basically predominantly diagnosed in autopsy, even in the developed country. Why? Because there is a lack of expertise in identifying these pathogenic amoeba. And the culture methods, everybody is not very well versed with. We do the workshop every year. If you are interested, we are doing in February, March time. So PGs can join at that time in my department, and we'll show you how to do proper culture using different other than E. coli and other bacterial isolates. Okay, on non-mutant agar and other PCR also we can give you hands on. The other problem in India is that there is a resource allocation, is a problem. Majority of the resources are prioritized for prominent diseases like HIV, tuberculosis, and malaria. So people are not paying interest in them, right? And they're not very well aware. But actually, as I told you, we are recently seeing a surge of these type of cases in the community. So with this, I'll take 5 minutes break. And if you have any questions, you can put in the chat box. Madam, can you hear me?
Yes, sir. Yes, sir.
Yeah.
Sir, at present, there is just one question in the chat box, which
Yes,
says that your voice dropped at some point when you were talking about the SLE patient who presented with acanthamoeba.
okay.
So there is a participant who would like to know what was the source of infection in that patient.
Yeah, that's what I told you at that time only, that we could not find that whether water is a source or not. There were no contact lens, usage in that case, and there were no skin trauma as well. So then we suspected that it could be that aerosolized route. Okay, from the dust particles might have entered the patient, nose, and that's how it might have, affected the lungs. It is basically inhalational route which was a cause in that case. And the patient was SLE and diabetic, so definitely risk factor were present in that case. And she was from Goa, and she was working in this recreational clubs are there, now water recreational. So she was working there, but actually water source per se were not there, because we have told her to get the water afterward on follow up. And I think we have done testing on the water, but we couldn't find anything. Even she was not a contact lens wearer as well. Okay, ma'am.
So we have some more questions. Would you take them now or
Okay,
later?
it is a 5 minute break just to drink water. So I'll go and drink water.
Okay,
And
sure, sir. We'll
let
take them
other
at
let other people also drink the water. Okay. And
Sure, sir.
then we'll continue, ma'am. Okay.
Yes, yes.
Okay. Thank you. Okay, shall we start, madam?
Yes, yes, sir. Yes, sir. Please.
All right. Okay. Yes. I hope everyone is back and everybody has drank water, not tea. All right. Okay. So I want your answer. Please write your answer in chat box. A 31-year-old man presented with a new onset seizure followed by lethargy, confusion. Neuroimaging revealed a partially calcified cystic lesion in the left frontal lobe. So, what is your diagnosis? Can anybody tell me? Okay. Uh, okay. Usha is saying tinea, Praveen, NCC, Risha, Toxo, Neuro. One plus is showing Neuro, Lakshmi, Toxo, NCC, Neurocystic psychosis. Okay. Uh, by seeing one picture, can you make the diagnosis? That's very important. That's quite interesting. So I think both of you, those who are, yeah, good, Drisya. So only on the CT scan, you cannot say that it is, toxo or it is neurocystic psychosis. You can't say like that. Okay. So my question is wrong. What is your diagnosis mean? It should be what is your differential diagnosis. So then that question makes sense, right? So I'll tell you more about this CT scan, and it was around 3 to 2 centimeter complex, lesion which was calcified, cystic, and it was present in the left frontal lobe in this case. MRI also confirmed a bilobed cystic mass in the same area. So now I am again and again saying cystic calcified with the new onset epilepsy. Okay, because the patient has presented with new onset epilepsy, cystic mass, as well as it was calcified. Then biopsy was done in this case, which confirmed the cysticercosis. Serology as well, it was positive for neurocysticercosis. Okay, so ultimately this case was found to be a case of neurocysticercosis. Can anybody, put in chat box what is the criteria to diagnose cysticercosis? I just want you to know what is the criteria to say it's a cysticercosis. There is one criteria. I'll not name the criteria. I'll tell you. I will reveal. If anybody can tell me. No one is typing. Okay, no problem. No problem. No issues. So, what was the status of neurocysticercosis in India? So, it is prevalent in the northern states of Bihar, Uttar Pradesh, Orissa, and Punjab. And usually, rural big farming community of Maholganj, Mohanlal Ganj block of Lucknow district, Uttar Pradesh. The prevalence was found to be around 18.6%. NIMHANS also did the study where they found NCC of in around 2% of the epileptic patients. In study from New Delhi, NCC accounted for 2.5% of all intracranial space occupying lesions. And 95% of the cases which got neurocysticercosis were vegetarians. 95%. Okay, this is quite important. So this is global, map which is showing that what all regions are endemic. So the India is quite endemic. Central part of the Africa is endemic, and South America is also endemic for neurocysticercosis. So this is a cysticercus larvae, okay, which consists of a scolex. This is a white color thing you can see here at the center, and it is surrounded by the bladder. Can you see the bladder here? Yeah, this is a bladder, and it is a thin wall cyst which is filled with a fluid. Okay, and here in the right side you can see the cyst inside the muscle. Okay. So how does human acquire the infections? So human acquire the infections after eating pork containing the cysticercus cellulose larvae. So what happens? Scolex exvaginates and anchor the small intestine and transform into the adult form. Okay, so here, larva emerges in the small intestine, mature into the adult form. Okay, so you can see here the adult worm. Can anybody tell me the size of the worm? You can write in the chat box. Size. Okay, so there you can see here they are present in the intestines. So this has been extracted from the intestines during surgery. 2 meter, 4 meter, 2 to 7 meter. Okay. Any more guesses? 4 to 5 meter. 5 millimeter. Anita, it's not millimeter. Is it millimeter? This picture, can you see here? Do you think it's millimeter? 15 to 20 meter? No meters. Okay, fine. All right. So you can see here, they are basically extracting the adult worm from the intestine. It's quite long. So these are the tinea eggs which are released from the human intestines. Okay. So what happened then? Cow or the pigs, in which these larvae hatches, these oncospheres larva basically migrates to the various tissues and convert into the infective cysticercus larval stage, and then new cycle begins. Right? How happily he is eating. All right. So humans are the definitive host and pigs are the intermediate host. See, humans will not get cysticercosis by eating the infected pork. Okay, if they ingest, they will not get cysticercosis. They will only get the cysticercosis if they ingest the Taenia solium eggs, either by fecal contamination. Okay, so then only the cysticercosis will occur, right? And pigs as well, they ingest the Taenia solium eggs or the proglottids, and then they may suffer from porcine cysticercosis. So humans will get infection or neurocysticercosis after ingesting only the Taenia solium eggs. So how the patient presents? Clinically, most of the cases are asymptomatic, but patient often notice proglottids in their feces, which may crawl and cause irritation. We had also, few of the cases which came to us, and the patient bought that white proglottids worms in the bottle, or one person has got in the matchstick. So that was quite interesting. And there were certain other non-specific symptoms like diarrhea, abdominal pain, appetite change, and slight weight loss. So human cysticercosis result from accidental ingestion, as I told you, of Taenia solium eggs from contaminated food, water, or soil. Oncosphere invade the bloodstream, and then they reach the various tissue, especially the commonly muscle. Okay, and causing the symptoms that can vary by the cyst location. Okay, it all depends where the cyst is located. So published articles or studies have shown that around 79% of the cases presented with seizures. So the most common symptoms in these cases is seizures, like 79% of the cases. 38% with the headache, and 12% of the, like 11.7% with intracranial hypertension. So these are the major symptoms. So 78% with seizure, along with some cystic lesion in the brain. तो तुम्हारे दिमाग का बल्ब चलना चाहिए. Okay, your mind bulb should switch on, right? So what is the size of the cyst in the brain? Actually, it is around 5 to 20 millimeter. Okay. There are certain cysts which are present, which are quite large and they occur in clusters. So they are called as racemo cyst. So here you can see this surgery is being done in the brain, and where the neurosurgeon is trying to remove the cyst from the brain. So this patient actually has presented with severe headache, seizure, and he had, blurring of vision. And there was cerebral infarct was also present. You can see the cyst here, how big the cyst is. And then this patient finally, died. So everybody has seen the size of the cyst. This is called as racemo cyst, and it could be sometimes 10 centimeter in size. Uh, Ocular, presentations are also there. This is a cyst which is floating in the eye. This patient has presented with proptosis, diplopia, and loss of vision. Okay. So this is a case of a 28-year-old male presented with 6-year history of recurrent generalized tonic-clonic seizure, 2-year history of disseminated body nodules. You can see the nodules, subcutaneous nodules, right? And these X-rays also showed multiple calcified lesions in subcutaneous, as well as neuroimaging also showed multiple degenerative lesion in the brain. You can see here, right? That's why the patient was suffering from epilepsy. So now question as a microbiologist comes to your mind, how will we diagnose it? Okay, so on what criteria? Some of you have already written that Del-Bruto criteria is there, which is a classical criteria to diagnose it. Okay, so then we have to do the antigen detection test, which is the first test we are supposed to do, using monoclonal antibody to in a capture ELISA format. So ultimately what happened here, the detection of antigen could be used to monitor the effect of therapy. So this EITB levels, okay, antibody level, falls rapidly after starting the therapy, but they remain positive in persons who are having, previous parasitic antigen exposure. But within 3 months, after successful, treatment, these levels decreases, and it's a quite a most useful test. Okay, the most useful test is Western blot, which basically employs a specific fraction of tinea solium cyst. Then we have enzyme-linked immuno electrotransfer blot, EITB, which is the best serological test for diagnosis of NCC. The sensitivity is quite high, that is 98%, specificity is 100%, and it only detects the antibodies to the larval antigen and does not necessarily indicate it is an active disease. And there was a study which was performed in CMC Vellore, and they found that seroprevalence with positive EITB was more than 15% of the large sample of asymptomatic person residing in Vellore district, right? And then histopathological diagnosis is also very, very important. Cysticercosis will appear as, by white fluid-filled bladder, which I've already told you, and it is around 5 to 20 millimeter in the brain, containing up to 2 millimeter long larval tapeworm scolex. Okay, so here you can see the multiple cysts, that white color cyst, right? So what is the criteria? Somebody told me Del-Bruto criteria. So what is Del-Bruto criteria? They are saying it's a confusing criteria. Why it is confusing? It's not a confusing criteria at all, actually. Hmm? Mhm. See, yeah, confusing criteria. Why they are saying is because I can't memorize it. Okay, I will at the end of this. See, there is a absolute criteria, there is a major criteria, there is a minor criteria, there is a epidemiological criteria. Okay, so at the end of this lecture, I will give you one slide. You can take screenshot of it, then it will be easy for you to remember it, right? Okay, I will tell you later. Next, my slides are so many, so I want to finish it off. Okay, A 43-year-old HIV positive truck driver presented with 15 days history of high fever, headache, 2 days of altered mental status, recent seizures, agitation, and disorientation. CD4 count was found to be 30 cells per microliter. Viral load was 240,000 copies per ml. Patient was evaluated for opportunistic CNS infection, including toxoplasma, tuberculoma, and cryptococcosis. The workup was done in this case. MRI brain revealed well-defined intraaxial lesion in the left cerebrum, pons, and the basal ganglia with perilesional edema. Here you can see these arrows. The toxoplasma serology show elevated IgG antibody level of 81 international unit per ml. What is the normal level? Anybody can help me? It should be less than 5. Okay, it should be less than 5. Okay. If it is more than 12 international unit IgG, then it is positive. Okay, if more than 12, it is positive. Okay, just remember that. So in our case, it is 81 international unit per ml, which is significantly elevated. Okay, and clearly positive. So it could be past or it could be current toxoplasma infection. We will evaluate further. So post-treatment MRI was done. So you can see all the perilesional edema was gone. Okay, the patient was put on mannitol, cotrimoxazole, and antiretroviral drugs with folic acid. Patient condition improved after 15 days of, and this is a repeated CT scan, show marked reduction in the brain edema, and there were no lesions, means lesions are not able to see, we are not able to see. And the patient was discharged on antiretroviral therapy. And then prophylaxis with a cotrimoxazole was also given, along with the anti-convulsion therapy in this case. So basically, a global study was done, okay, of Toxoplasma gondii IgG seroprevalence, which includes 7,23,655 pregnant women, with the data collected from 1976 to 2017. Okay, so this was a quite significant study, and here you can see different colors like green color, light green, yellow, orange, red. So basically, what does it show? This legend actually is showing the seroprevalence percentage. So this legend, what you can see is IgG seroprevalence, is showing the percentages of seroprevalence. So green means less than 10%, light green 10 to 20 or 19.999%. Yellow is 20 to 29.99%. So where India stands? Yellow color. So in India, the seroprevalence of Toxoplasma is 20 to 29.99%. And there are certain, dark red areas are also there, okay, where the prevalence is more than 50%, right? Okay, so basically, this is a seroprevalence study which was conducted in, pregnant women by our center in collaboration with AIMS Delhi. Okay, so as I've already told you that in India, overall prevalence in this study was found to be 22.4%, and it was found highest in the south. Okay, 37.3%. So I think some lovers are there out there. Our PGs are lover. I mean to say cat lovers. Okay. So a lot of cats are there in the South India, and people keep at home and they clean their litter boxes. Okay, and they do gardening and all. So cat has a direct relationship with it. So we found the seroprevalence of 37.3%. So what are the risk factors actually? Lower socio-economical status, mud houses, raw salad intake, untreated water, pet ownership, and advanced age was a risk factor for this type of prevalence which was seen in South India. See, diagnosis is quite critical in these 4 groups. Okay, why it is critical in these 4 groups? Suppose a maternal fetal transmission occur, it can cause fetal brain damage, it can cause blindness, it can cause death of the child. Then congenital complications are also there like hydrocephalus, chorioretinitis, mental retardation in newborn. And then, like in HIV patient, immunocompromised patient, like cerebral toxoplasmosis can be life-threatening itself. And if it occurs in the eye, then it can lead to blindness and other complications, okay, like chorioretinitis. So this is a child with hydrocephalus due to congenital toxoplasmosis. So this is a classical picture you'll never forget in your life. Okay, what does this diagram illustrates? Actually, this shows the transmission route and the life cycle. So here you can see the cats, phthalates, which are definitive hosts, which can shed infectious oocyst after consuming the infected prey. And then so these are the primary environmental source. So cats are the primary, or these phthalates are the primary environmental source for these oocysts, and they can cause environmental contamination. So it can contaminate water, soil. uh, these oocysts can survive on the plants, vegetables, right? So food chain transmission can also occur. Like these cattle, sheep, pigs, or the birds, they can get infected by ingesting the contaminated plants. While these carnivores, like bear in this picture, which can get infected by eating infected herbivores, right? So this is a transmission of the life cycle in animals. How does humans get the infection? So in humans, foodborne is the most common cause, like raw or undercooked meat from the infected animals, okay, which are containing the tissue cyst, okay, and which may survive because of inadequate cooking. Then there is a environmental contact, like cat feces exposure, like litter boxes or gardening. If like this lady is doing the gardening and cleaning the litter boxes, or contaminated vegetables and soil, hand to mouth transmission of the oocyst can also be possible. Okay. So what about the vertical transmission? Yes, vertical transmission can also occur uh, during the pregnancy. And parasites basically cross placenta to the fetus, and then they can cause congenital toxoplasmosis, right? So how do you diagnose this is very important. So either you can directly detect it, you can isolate the toxoplasma from the brain tissue, right? Or from the lymph node tissue, if they are there, lymphadenopathy is present. You can look for presence of tachyzoids or the bradyzoids. So this is a bradyzoid. Bradyzoids are nothing but they are the slow dividing forms of toxoplasma. So what are these? These are called as tachyzoids. So they are basically crescent or banana shaped organisms, and the size is around 2 to 6 micrometer in length, 1 to 3 micrometer in width. They are elongated, curved morphology, with a tapering end. And if you see microscopically, this stain is Giemsa stain, or you can use any similar stain like Leishman stain. And you here a single nucleus is visible, okay, which is darkly stained as compared to the cytoplasm. Okay, so cytoplasm is appearing a little lighter purple, or purplish or blue color. And here you can see the clustering or the group arrangement. Okay. So what is the importance of these tachyzoids? What is the importance of these? Okay. So they are rapidly multiplying forms. They are invasive in nature, and they are majority of the cases they are seen in acute infection. And where they are present? They are present in the CSF, tissue biopsies. Uh, uh, if you see the bradyzoids, how to differentiate from the bradyzoids? The bradyzoids, if you see in the tissues and all, they are basically slow dividing forms. But these tachyzoids are fast or actively dividing forms and seen in acute infection most commonly. Then you can detect the antigens. Okay, so antigenemia, the presence of Toxoplasma gondii antigens, or like proteins circulating in the blood. So 65.2% is the percentage of the patient with acute toxoplasma. If antigemia is there, then it means that around 66% of the cases are suffering from acute toxoplasmosis. Okay. If no antigen is detected, it means that it could be a chronic infection. It could be chronic infection. So toxoplasma antibody testing. Now, many people get confused with these antibody testing. So just pay attention here. Okay. See these IgM and IgA. they represent the acute or the recent infection, right? And they basically rise and fall together with each other. Like IgM and IgG have a parallel pattern. So if IgA is rising, IgM will also rise. Okay. The cutoff is 100, more than 100% of the cutoff value, which is varies from manufacturer in case of IgA. IgM can be detected by double sandwich IgM ELISA, okay, which provide the greater accuracy. Okay. So here more than 10 AU per ml. AU, if somebody can tell me what is A means here. Okay. So the positive depend on the lab, varies from 9 to 12 AU per ml. IgG appear 1 to 2 weeks post infection and peak around 1 to 2 months. And the positive is more than 12 international units per ml. Right. Some labs consider more than 8.8 as a positive. So here in this is a diagram where you can see different type of lines. You can see red line, green line, blue line, dotted lines. So what does it mean actually? Okay. So this red line is basically IgM, which appears first, rises quickly, and then it peaks within a month, and then it declines after 2 to 3 months. So what does it indicate? It indicates acute or recent infection. Okay, now what is this green line? This is a IgA level, and it has a similar pattern to that of IgM. It rises and falls together along with IgM. It also peaks early, then declines. And these IgA levels are quite important in the way that they are more sensitive than IgM in newborn babies. Okay. Then IgG, which is a blue line. There are two blue lines. One is dotted, another is a solid line. So this solid line is basically the detection of IgG level by ELISA test. Okay. So it is more sensitive and it rises quite higher as compared to the other levels. And other is this dotted blue line. Basically here IgG was detected by IFAT, immunofluorescent antibody test, and Sabin-Feldman dye test. Okay, they are less sensitive as compared to ELISA. That's why we prefer always to check for IgG level using ELISA test. Okay, so then these IgG basically plateau after 2 to 3 months. Here you can see 2 to 3 months they'll get plateau. Okay, but then they may persist for lifelong. Okay, and they indicate past infection. So if IgM, what is the clinical significance? How to interpret it? If IgM and IgA positive is there, okay, and IgG is low or negative initially, then it could be acute infection. In chronic, what is chronic infection? Acute infection is like 0 to 2 months. Just remember that. Acute infection is 0 to 2 months. Chronic infection in toxoplasma is considered more than 6 months. Okay. So in that, IgG level will be positive and it will be persistent, while IgM and IgGA level will be negative or it will be very, very low. Okay. So toxoplasma infection in pregnancy is quite important in the sense that you have to do the serial antibody testing. You will look for the rising antibody titer in the sample collected 3 weeks apart and tested in parallel. Okay. And there should be 4-fold rise in the titer. Means suppose initial titer was 1:64, then it should rise up to 1:256, which confirm the acute infection when samples are tested simultaneously. Okay, that is called as parallel testing. Okay. IgG avidity testing now. Many people, many students get confused with IgG avidity. I'll try to explain it. So it basically, what is avidity means? Avidity means binding strength of the IgG antibodies to distinguish between the recent and the past infection. So suppose there is a high avidity in the first trimester. You have the pregnant lady has come to you. Okay, the sample has come in the lab, and she is in the first trimester, and you found that IgG higher avidity. It means that she got infection more than 3 months before the pregnancy. So means the infection has occurred before the conception, and fetus is not at risk of congenital toxoplasmosis. This is very important. But if low avidity is there in the first trimester, then it means that it is a recent infection within 3 months. And may have occurred during the pregnancy, means the lady might have got the infection during her pregnancy, and in that case fetus is at risk. Okay, so what we should do then? We should further monitor. How? Oh, this is quite a complicated diagram, but I'll try to make it easy. So you start with IgG test first. Okay, for example, IgG is found to be negative. It means that no infection detected. Okay, but clinician is saying I am suspecting acute infection. Then you do the retesting with IgG antibodies after 3 weeks. Okay, you do the retesting after 3 weeks. Suppose IgG comes positive, then infection is confirmed. Then what do? You proceed with the IgM levels. Okay, IgM testing. Okay, for example, IgG is positive, but IgM is negative. Then it means that infection occurred more than 1 year ago. Means it is a chronic infection. Means IgG positive, but IgM negative. It means that infection is chronic in nature. Okay. But if IgM comes positive, infection within the last 2 years, you should remember, or possibly, okay. Some people say, when I was discussing with Dr. Sarman Singh once, he told me that sometime Dr. Sarman Singh is authority in toxoplasma. He was in Delhi earlier, AIMS Delhi. So he told me that many of the time positive IgM also comes. So if positive IgM comes, you should not stop here. You should not label the patient as he's suffering from acute toxoplasmosis. You should proceed with the avidity ELISA, IgG avidity test. If IgG and IgM is positive, then it is a high avidity and infection may be at least 12 weeks old. Okay, if the avidity is high, infection is more than 12 weeks or 3 months prior it has happened. Okay, if low avidity, as I have already told you, collect a second sample. See, you should not stop here. You should not label the patient. Collect the second sample again 2 weeks later and send both the samples to some reference center like AIMS Delhi for confirmation before starting any treatment or any intervention. I hope I'm clear. This is quite important for you to know, but I think madam might be having a recording. You may listen to that. So it's quite important to diagnose these cases in this way, right? So what is the take home message? Okay, development of urgent need is development of specific sensitive molecular diagnostic like PCR, especially for new pathogens like worm amoeba, vermiformis, Balamuthia, Sapinia diploideae. Okay, tetramatis. All these are recent advances where you require a quite sensitive molecular test. Better serodiagnostic test can differentiate between acute and chronic infection. Standardized diagnostic algorithm has to be followed, which combines serology, molecular method, and imaging. What is the bottom line then? The success depends on the high clinical suspicion, rapid multimodal diagnosis, and early treatment initiation. Then only your patient will be saved and you will be happy at the end of the day. Thank you so much. With this, I end my presentation.
Thank you, sir, for that very lucid, comprehensive coverage of the neuroinvaders. And also, I'm glad to inform you that there were close to 90 to 100 participants with you for the last almost 1.5 hours. And
Oh, great.
now, I think quickly, if we can take a few questions. Sir, shall I go with the questions now?
Yeah, sure, ma'am. Sure.
Yes. There is a question. This, I think, is on reliving amoebae, which says, is water the most common source of infection or soil?
Yeah, fresh warm water are the most common source, ma'am. Soil is in case of Balamuthia.
Right. So next one is, why are these cases only in Kerala most of the times reported?
Yeah, so if you can read the published article, they have seen that first of all, these heavy rains which occur in Kerala, and in some of the houses in front of them, they have a what do you say, water. These long pipes are there, okay, or where the water flows and they are open. Okay, these tunnels, okay, I should not say tunnels, but they are like small puddles, you can say that. So some kids go and take bath over there, and they have reported all these. In the case, I was also quite fascinated because one of the patient who presented to the pediatrician, the father told that after rain, he went in front of the house. There was one big nala, you say in Hindi, okay, and because rainwater was coming, and he took bath over there, and he was very happily playing in that water. And later on, he might have ingested or maybe inhaled that water, and that's how he got. That's how the clinician or the pediatrician suspected the case, and ultimately that boy died, and it has been reported. Okay, I'm not saying from my side. If you go and read the articles, quite interesting cases. So
Okay.
mainly Kerala, because there is a water stagnation, and the kids have a habit of playing in these water bodies. And recently I have told you that the studies are being coming, which are correlating climate change along with increase in the cases. Yes, ma'am.
So there's another question. Thanks for that answer. There's another question which says, are there any environmental studies on free living amoeba in India, and what is the status?
Okay, see, environmental studies are there. Actually, not many studies are there, but there are few studies. Uh, I can send those links to the interested one. You can share my email, ma'am. My email is drvinaykmc@gmail.com. You can write it down, means the participant can write down. And if they want, I can send few of the articles for them to read about it.
Sure, sir. Sure, sure. Thanks for that. And the next question is, please elaborate regarding the molecular diagnostics for free living amoeba.
What they want me to elaborate. See, there are two types of PCR which are commonly done. One is genus specific, another is species specific PCR, which is being done. So majority of the time, the labs are not well, means they don't have real-time PCR and all. We in our lab we have real-time PCR, but most of the time we do the conventional PCR, okay, which are genus specific. But after that, doing PCR which are genus specific, you have to go for the species. So better to go for sequencing, which will help you better to understand what type of species or uh, the pattern you are, or the type of species you are dealing with in your cases. And you have to correlate with the environment also. You have to basically take the sample from the patient surroundings as well, and then try to correlate whether the same sequence is being reported in the environmental sample or not, or it is one of its own kind.
Yes, sir. Thank you, sir. And one more question, sir. What about that infant? The case of that infant that you had presented. Was there any source that was identified?
Primary amoebic meningoencephalitis. Actually, ma'am, we have reported two cases. Okay, one case was reported long back. The reason was swimming pool. It was one of our staff here. Okay, daughter died, and the reason was swimming pool, and then pool was closed for many months. Proper chlorination was done, and then later on it was open for the public. So that was the first source. But second source, which I have presented here in this presentation, we could not able to find the source. How he got the infection, we don't know. And we have seen, ma'am, recently we have got a few cases of acanthamoeba. Some of the, now water activities are quite increasing. And the case which we have reported recently, I think a month back or so, that girl has a habit of putting water in one nose and try to, remove the water from the other. This is basically some therapy they do in Ayurveda. Okay, that's how, with that history, we found that, okay, she got the acanthamoeba because of that reason. Okay, so then, you have to be extra careful with the water bodies. And I'm not scaring anyone, but there are certain, WHO criteria. They say that whenever if you are doing swimming and all, you at least put clips on your nose, and then you swim. Like that, there are certain criteria, WHO criteria are there, how to prevent these type of diseases.
Right, sir. And one last question, sir. After inoculation of CSF sample for acanthamoeba, on E. coli lawn culture, till what day do we wait to say that the culture is negative?
That's a good question. In my lab, we'll wait for 10 days, man. Okay, up to 10 days. But in my experience, by 48 to 72 hours, we would be able to appreciate the trophozoites. Okay, and the cysts. Cyst will come little later, but trophozoite at least we can start appreciating them.
Right, sir. So that brings us to the end of the questions. And before we take leave, I thank each one of you for your active participation. And Dr. Vinay, sir, thanks to you especially for making this session so interesting, very informative to our postgraduates and to us. And special thanks to IMMKC, the executive committee, and the masterclass coordinators. So once again, thanks one and all. Please remember, participants, I will leave this meeting on for next couple of minutes. If you still have questions, please feel free to put them and we shall get them to Dr. Vinay and try to reach out to you.
You can share my number, ma'am. My not
Yes.
number, my
I said
email.
your email.
Yeah.
Somebody is asking for their email to be repeated once
Okay,
again.
I will write down in the chat box. Okay, so they can see and mail me.
And thank you, Vinay sir, for this session.
No
and
problem.
Participants, please note the recording will be also made available for you.
I have shared my email.
Thank you, sir. Thank you for that.
Okay. All right. Thank you so much, ma'am. So shall
Thanks,
I leave
sir.
now?
Yes, sir. Thank you, sir. Thank you.
All right. Thank you so much. Bye. Bye, everyone.